Hello everyone, my name is Dr. Abdulla Rahoomi, a consultant of physical medicine and rehabilitation. Today I would like to speak to you about certain aspects of stroke rehabilitation. As you might know, stroke is considered to be one of the most common causes of adult onset disability, and is considered to be the second leading cause of death and the third leading cause of disability adjusted life years worldwide. It's considered also to be the fifth leading cause of death and a leading cause of long-term disability in the United States. It has a tremendous economical impact, and its medical costs are estimated or were estimated to be 71 billion in 2012, while it's expected to increase to 184 billion in 2030. Over 25% of patients suffering from stroke suffer from functional disability at discharge, and therefore stand to benefit from early rehabilitation and rehabilitation in general. 70 to 85% of first stroke patients are suffering from hemiplegia, and approximately 60% of them achieve functional independence in the activities of daily living at discharge from rehabilitation. The site and extent and nature of stroke are determinants of functional recovery, and it's often hindered, or the recovery is often hindered above all by the involvement of major white matter tracts and the damage of or disconnection of the hippocampus, which, as you know, has a role in learning and relearning of neurological functions. The absence of pre-existing damage in the form of subclinical vascular lesions plays an important role in recovery, and accordingly, persons who had led an active lifestyle until just before the strokes, and those who do not have a degree of white matter damage have been found to recover particularly well from stroke. Thus, pre-existing brain damage is probably more important than age as a determinant factor for recovery. The rehabilitation post-stroke includes an organized multidisciplinary team, supportive services that begin approximately at about 48 hours after stroke onset. And it aims into maximizing the function of the brain areas that survive the stroke and to compensate with the unaffected arm or leg. Physical, occupational, and speech therapies primarily build skills and change the environment to maintain the patients at home with as little care as possible. Problem solving, supportive social, psychological services, removal of architectural barriers to mobility, braces, and other orthotics and devices such as wheelchairs, walkers, continue to play an important role in helping the patients to regain mobility and to remain independent. The period of, it has to be said that the period of maximal neuroplasticity in humans is not entirely clear, but it is hypothesized to be between 1 to 3 months. And certain medications can impair the post-stroke recovery and the plasticity in the brain, in particular when used in the acute period, and should be avoided if possible, such as the H2 blockers or the older anti-epileptic agents. Genetic polymorphism and differential gene regulation could provide both early biomarkers for recovery and also to target rehabilitation therapy. And I believe that this is probably the future of rehabilitation in stroke, that the genetic polymorphism will play a different role in the upcoming years in the rehabilitation process. Stroke rehabilitation is divided into certain phases. Usually we can divide it in 6 different phases, while the early one is mainly related to early neurological rehabilitation, which starts by early mobilization. The second phase is the phase where it requires patients intensive care usually, and high demand of medical issues that could hinder or limit the rehabilitation process. The third phase of stroke rehabilitation is usually the phase where patients are actively participating in rehabilitation, yet still they are complaining from, or they are suffering from medical issues that require their inpatient admission in a facility that provides medical care. The phase D corresponds to the idea of rehabilitation in the narrower definition of post-hospital curative treatment, and phase E is mainly related to occupational reintegration, while the phase F is continuing the measures to support, maintain, and improve the functions that has been achieved in the previous phases of rehabilitation. The inpatient rehabilitation facilities are usually intensive centers that provide 24/7 hospital care level, and it's usually for patients who are likely to return to community rather than skilled nursing or long care facilities. And it's usually available to patients who are able to actively participate in at least 2 disciplines of therapy, such as physical therapy, occupational therapy, speech and language therapy for approximately 3 hours per day, and also have medical issues requiring physician supervision. There are skilled nursing homes, which is usually for long-term residential care for individuals unable to live in the community. The long-term acute care hospitals, which are extended care to stroke patients with complex medical issues due to a combination of acute and chronic conditions. Home therapies, which is therapy provided at home. It's a less intense type of rehabilitation, which we are not going to target today because we are going to discuss mainly the inpatient rehabilitation. The ideal team of rehabilitation is usually composed of physical medicine and rehabilitation consultants or physicians, a neurologist, rehabilitation nursing, physical therapy, occupational therapy, speech and language therapy, social workers, psychology, psychiatry, and counselors. The rehabilitation should start as soon as the patient is ready and can tolerate it. Patients should undergo a formal assessment of rehabilitation needs prior to discharge from acute care. Overall, approximately 32% of patients discharged from acute care end up in nursing facilities, while 22% end up approximately in rehabilitation facilities and 15% in home care. In comparison to acute stroke units, acute rehabilitation units have a greater emphasis on recovery and rehabilitation, increased staff education and training, greater patients and caregiver participation, early mobilization protocols. And there is a strong evidence that an organized interprofessional stroke care reduces mortality rates, reduces the likelihood of institutional care, reduces the long-term disability, and enhances recovery and increases the independence of activities of daily living. The timing and intensity of rehabilitation are important issues, but remains controversial. Stroke survivors should receive a rehabilitation at an intensity proportional to the anticipated benefits and tolerance, and a high dose, very early mobilization within the 24 hours onset reduces the odds of a favorable outcome at 3 months and is not often recommended. Stroke survivors are often at a high risk of deep venous thrombosis and pulmonary embolism. That's why we need to pay a special attention to these issues which are arising from mobility and reduced activity level. The prevention with pharmacological and mechanical treatments should be considered in both hemorrhagic and ischemic strokes. Prophylactic treatment is initiated depending upon the type of stroke and the use of thrombolytic therapy, while the prophylactic treatment is often continued throughout the rehabilitation stay or until the stroke survivor regains mobility. Disability assessment is an important part of rehabilitation, and usually in the acute phase, we focus on certain aspects such as the cognitive changes, visual field deficits, aphasia, neglect, dysarthria, weakness, sensory deficits, coordination problems, and major depression. While in the chronic phase, our assessment is often targeted toward the activity limitation, restriction of participation, and the quality of life. The disability assessment is often carried out by different type of scales and assessment methods. I have listed few here for your reference, but there are many others that we are using in rehabilitation that are validated and could be used by people in the rehabilitation facilities. The activities of daily living are important to the patients, and it's very important to provide a formal assessment prior to discharge from acute care and at the beginning of the admission into our rehabilitation facilities. And the post-acute rehabilitation needs to be tailored, as I said previously, to the according to the patient's need and condition, and we need to take into account different aspects such as the residual neurological deficits, the activity limitation, cognitive limitations, psychological status, swallowing abilities, previous functional ability, the medical comorbidities, level of family care, likelihood of returning to community, and participation in rehabilitation. Usually, we carry out our first follow-up of the assessment of activities of daily living at about 1 month from early discharge. And as I said also previously, the use of standardized measures is useful to document the severity and also to follow up the improvements of rehabilitation. And often, if the patient is able to walk, a standardized measure of balance and gait is often carried out. The walking rehabilitation, our aim in rehabilitation is usually to get the patient out of bed within approximately 2 days, as long as the patient is hemodynamically stable. The aims are to prevent functional impairments through mobilization over the edge of the bed into a wheelchair, practicing transfers, driving a wheelchair, and standing up at a standing desk. The benefits of verticalization include circulatory training, prevention of pneumonia and venous thrombosis, stimulation of the autonomic nervous system, prevention of pressure sores, for example, and also the sensory activation through standing. Training of ambulation could begin once the patient is able to tolerate sitting and standing for about 10 minutes. The arm and hand functions. It's important to train the patient's arm and hand function with repetitive practice, focus on strength, coordination, and speed. The integration of hand function into the patient's everyday activities is also important. And a good evidence of the constraint-induced movement therapy has been shown in literature, especially in the periods between 3 to 9 months post-stroke. And in cases of severe weaknesses, the passive and assistive therapy should be provided to the patient with the use of facilitation techniques. Now, bowel and bladder deficits or issues arise with patients with stroke, and they are quite common. 40 to 60% of stroke patients have a certain degree of urinary incontinence, falling to approximately 25% at discharge and at approximately 15% at 1 year, while fecal incontinence prevalence is approximately 40% in the acute phase, falling to approximately 20% at discharge. The impaired awareness of incontinence is often correlated with higher mortality and the need for nursing at about 3 months post-stroke. The recommendations in rehabilitation should be through a detailed history in the beginning, the assessment of urinary retention throughout bladder scanning or intermittent catheterization post-voiding, the assessment of cognitive awareness and impairments, removal of Foley's catheter within 24 hours after admission to rehabilitation, prompted voiding and pelvic floor muscle training should be considered in such patients, and the assessment of stool consistency, frequency, and timing, and bowel care practices. The central pain also is another issue arising in rehabilitation, and it results usually from lesions in the somatosensory system rather than from a nociceptive or a psychogenic cause. The diagnostic criteria often is through a pain occurring after stroke, located in the area of the body that corresponds with the lesion of the central nervous system, and not accounted for by a nociceptive or a peripheral neuropathic pain. Central pain is classically associated with thalamic stroke, but can also result from lesions anywhere in the spinothalamic or thalamocortical tracts. And it's often described as a burning or aching pain. Its incidence is approximately 7 to 8% and typically starts a few days after stroke. Central pain treatment should be in combination between pharmacotherapy, and therapeutic exercise and psychological support. And the treatment should be individualized to patients' need, response to therapy, and the side effects. There are certain types of treatment which are used, such as antidepressants, anticonvulsants, amitriptyline, and lamotrigine, which should be used primarily. The other treatments that could be used in such cases, such as pregabalin, gabapentin, carbamazepine, and phenytoin, which could be considered as second-line treatment. Transcutaneous electrical stimulation remains controversial as an effective treatment, while motor cortex stimulation could be used in an unresponsive pain to the previous treatment which were mentioned. And there is a conflicting evidence regarding the deep brain stimulation in the treatment of central pain. Another important issue in rehabilitation is depression, and it's considered to be very common in post-stroke patients. It's often associated with increased mortality and can negatively impact patients' ability to participate in rehabilitation. The condition is treatable and accounts for approximately 33% of stroke survivors. There are certain predictors of depression in stroke, such as the prior history of depression, severe disability, cognitive impairment, previous stroke, positive family history of psychiatric disorders, and female gender. Depression assessment should be carried away in the beginning of the rehabilitation, and patients' education and counseling should be established and provided to patients surviving stroke. The consultations by psychiatrists or certified psychologists for stroke survivors should be implemented once needed, and the treatment should be combined with a 4-week exercise program in combination with the medical treatment. The early effective treatment of depression is often recommended and could be started with antidepressants in the absence of any contraindications. Selective serotonin reuptake inhibitors are commonly used and are well tolerated in patients, and they may also impact motor recovery, likely through neuroplastic mechanisms. Communication, cognition, and memory impairments are also encountered in rehabilitation, and they negatively impact participation in daily activities of the patients. And it's very important to identify the strength and compensatory strategies to maximize the patient's independence and reintegration into the rehabilitation process and into the community. The assessment should evaluate speech, language, cognitive communication, pragmatics, reading, and writing abilities and deficits. To identify the communicative strength and weaknesses of the patient, identify helpful compensatory strategies that the patient could use in the rehabilitation process. The cognitive impairments are estimated to be found in 1/3 of stroke patients between 3 to 12 months post-stroke, and are often associated with poor long-term survival, higher disability, greater hospitalization. And the domains that are mainly affected are the memory, orientation, language, and attention. There is an important role of cognitive rehabilitation, which is defined as a systemic, functionally oriented service of therapeutic cognitive activities based on assessment and understanding of the person's brain behavior deficits. It aims into restoring cognitive activity, the acquisition of strategies to compensate for the impaired cognition or cognitive function, the use of adaptive techniques or equipment. And it's often established in an enriched environment to increase the engagement of the patient. Specific memory training is often recommended for patients with cognitive deficits. Errorless learning techniques may be effective for persons with severe memory impairments. And music therapy has been shown to be used in patients and to improve verbal memory. Exercise as an adjunctive therapy to improve cognition and memory is often used. Poor evidence has been there regarding the virtual reality training, but it may be considered for verbal, visual, and spatial learning. There is a limited literature regarding the use of pharmacological therapies in cognitive impairment patients. The sensory impairments, there are different types of impairments, and for example, the loss of vision, it's presenting in numerous forms such as visual field deficits, abnormal eye movements, reduced acuity, diplopia, and other types. The visual field loss is the most common and accounts for approximately 30% of the patients. A variable degree of spontaneous restoration of fields generally occurs. And the treatments you often should focus on deficits in eye movements, deficits in the visual fields, and the visual, spatial, or perceptual deficits. The convergence insufficiency treatments by eye exercises should be implemented. Compensatory scanning training to improve functional activities of daily living. Yoked prisms should be or could be helpful to compensate for visual field cuts. And there is a limited evidence on computerized visual restoration training. There are other types of sensory impairments, such as loss of touch, proprioceptive deficits, hearing losses, and they are directly linked to activity limitations and participation restriction. These sensory impairments often improve with therapeutic interventions, and it is mandatory for patients or stroke survivors to undergo evaluation of all of the above mentioned sensory impairments in the rehabilitation units to be able to implement the solutions and the therapeutic interventions necessary. Another aspect which we encounter often in rehabilitation is dysphagia, and it accounts for approximately 42 to 67% of patients within 3 days post-stroke. 50% of these patients are at a risk of aspiration, and 33% of the patients are at a risk of pneumonia. It often predisposes the patient to certain risks, such as malnutrition, dehydration, weight loss, overall decreased quality of life. Early identification through screening can reduce the risk of developing the adverse health consequences, and it's often done by a speech language therapist or other trained healthcare providers. It's often conducted before the patient begins eating, drinking, or even receiving oral medications. And patients with a suspected aspiration risk might require an instrumental evaluation, such as video fluoroscopy or fiber optic endoscopic evaluations. The implementation of oral hygiene protocols are important in the rehabilitation process. Enteral feeding should be initiated within 7 days of stroke for a patient who cannot safely swallow, and short-term use of nasogastric tube feeding between 2 to 3 weeks is often recommended. Percutaneous gastrotomy tubes should be considered in patients with chronic dysphagia. Nutritional supplements are to be considered in malnourished patients or at a risk of it. Dysphagia treatment management could include behavioral interventions and acupuncture also. There are uncertain benefits of drug therapy, neuromuscular electrical stimulation, pharyngeal electrical stimulation, physical stimulation, transcranial direct current stimulation, and transcranial magnetic stimulation. Another aspect which we encounter in rehabilitation is the hemi-inattention or hemispatial neglect, which is not attributed to primary or sensory motor deficit and typically in the contralateral area to the lesion. Interventions developed fall in 2 general categories, such as the bottom-up approaches, which remediate the attention process and internal representation of spaces, and the other intervention, which is the top-down approaches, such as teaching the patient strategies for compensating for neglect. It is important to provide repeated top-down and bottom-up interventions, such as prism adaptations, visual scanning training, optokinetic stimulation, virtual reality, limb activation, mental imagery, and neck vibration combined with prism adaptations to improve neglect. Repetitive transcranial magnetic stimulation of various forms may be considered to ameliorate neglect syndromes. The aphasia recommendations: speech and language therapy is recommended for people with aphasia, and treatment should include communication partner training. There is no definitive agreement about intensive treatments, in particular the optimum amount, timing, intensity, distribution, or duration of treatment. The computerized treatments may be considered to supplement the treatments. Melodic intonations therapy has shown good results with patients suffering from expressive aphasia, but with some retained expressive abilities as well as absent bihemispheric damage. Community-based aphasia groups use is often encouraged, and brain stimulation techniques remains experimental in aphasia rehabilitation. Another important aspect of rehabilitation post-stroke is the management of spasticity, which is defined as the velocity-dependent resistance to stretch, and could have dystonic features sometimes, and it correlates often with activity limitations associated with hygiene, dressing, and pain. Botulinum toxin injections are a gold standard treatment, and it often aims to reduce spasticity, improve the passive or active range of motion, improve dressing, hygiene, position, or even gait. The oral agents are useful, but may result in dose-limiting sedation or other side effects. The use of neuromuscular electrical stimulation is useful in improving spasticity temporarily and is often used as an adjunct therapy. Baclofen pumps are useful in the severe spastic patients and not responding to other treatments. Postural training and task-oriented therapy are often considered in ataxic patients. The use of splints for spasticity prevention isn't recommended, while the use of splints could be used in the prevention of flexion contractures, whether in the upper or lower limbs, of course, as we have discussed previously before. In conclusion, stroke rehabilitation requires a sustained and a coordinated effort from a large team. The timing and intensity of acute rehabilitation are important issues, but remains controversial. Rehabilitation should start in the 48 hours after stabilizing the patient's condition, and it's very important to integrate the patient's goals, family, friends, and other caregivers in the plan, and also to coordinate and communicate between the involved members to maximize the efficacy and the effectiveness of the rehabilitation plan. And lastly, I would like to mention that robotic trainers and virtual reality practices provide essential benefits to the patients, but the literature remains limited in this aspect. Please feel free to use or to look at the references that I have used in this presentation for more details if needed. And I would like to thank you for your attention, and please don't hesitate to send me any questions or to raise any questions if you have them, and I will be more than happy to answer your questions. Thank you very much.